Hello everyone, thank you for coming. Welcome to this session of NAUTO's 36th Annual Conference. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. Now I will turn the stage over to Norm Thurston, NAUTO's Executive Director, who will start today's session.
Thank you, Marin. We're welcoming you to this afternoon's session on Code It, See It, Interpret It, Disparities during the COVID-19 pandemic. The session has been organized by Andrea Clark from BerryDunn and our sponsor is Maximus. So we're going to turn the time to Karen Holzer from Maximus for a brief introduction.
Good afternoon. My name is Dr. Karen Holzer, and I direct Maximus's new Public Health Data Analytics Division. It is my pleasure to sponsor today's session, Code It, See It, Interpret It, Disparities during the COVID-19 pandemic. Maximus, my company, is a large provider of integrated IT solutions. We help our government clients in public health and beyond deliver on their digital transformation initiatives and solve their most complex technological challenges. We are also the largest citizen service provider to the US government, serving over 60 million citizens each year. For instance, we help more than 65% of those in poverty get access to vital government benefits programs such as Medicaid, TANF, SNAP, and SSI, SSDI. We help millions of vulnerable individuals and families each year qualify and enroll in healthcare. And we support our nation's most vulnerable individuals in getting access to financial assistance, childcare, and employment retraining to support their move towards self-sufficiency. Over the past 18 months, we've supported government at all levels in their response to the COVID-19 pandemic, including with COVID-19 testing, contact tracing, and overcoming vaccine hesitancy. We operate the National COVID-19 Vaccine Hotline for CDC, CDC Info, and we support more than 23 states and localities for their COVID response. Through this work, we've seen time and again just how hard the COVID pandemic has hit our nation's most vulnerable individuals, and how inequities continue to disproportionately affect lives and livelihoods in underserved communities. We, like many of you, have struggled with persistent data challenges around race, ethnicity, and social determinants of health, and we have seen how good data, made accessible through data analytics, visualizations, and dashboards, can drive towards a more equitable response to the pandemic and better health outcomes. I'm looking forward to hearing from our esteemed colleagues this afternoon about their learnings. If you haven't already done so, please check out our exhibit booth. And thank you for making the fight against health disparities a priority in your work. If you haven't already done so, please check out our exhibit.
Now, welcome to the stage with me, Andrea Clark, today's moderator. Andrea, are you ready to go?
Indeed I am, Norm, thank you. All right. Our first presenter today in Code It, See It, Interpret It, Disparities during the COVID-19 pandemic is Traci of Comagine, presenting on the COVID-19 pandemic exposing inequities experienced by American Indian and Alaska Native populations in the United States. Traci is a health data analyst and visualization specialist, helping leaders make data-driven decisions to reimagine healthcare to be more patient-centered and effective in delivering on the promise of improved population health in our communities. Traci?
Welcome, and thank you for joining us. Today, we are going to start with why. Why would you code, visualize, and interpret health data stratified by race? One reason is that you need to identify disparities before you can work to alleviate them. I will be using an example to illustrate this idea in my presentation. I am Traci, a health data analyst at Comagine Health. I've been using data to improve healthcare processes and health outcomes for the last 22 plus years. Comagine Health is a national nonprofit healthcare consulting firm in the United States working to reimagine healthcare together with patients, health providers, and community partners across the United States. Remember what it was like about 18 months ago at the start of the pandemic? We did not yet have a good way to track data about what was happening across the country. Gradually, we started to collect data from outbreak areas, then across the country by state, and eventually by county. Even by summer of 2020, available data was still limited. At that time, Comagine Health was working with the Indian Health Service and tribal health partners to improve healthcare delivery in several American Indian communities across the country. We became alarmed about the impact of COVID-19 among those partner communities and wanted to raise awareness on behalf of our partners. However, COVID-19 case and death data by race was not yet available. Our biostatistician, Dr. Sunny El Ibrahimi, did some analysis to stratify COVID-19 case and death data by dividing counties into two groups using publicly available census data on race in county populations. She found significant differences when comparing counties with 20% or more of the population who were American Indian, Alaska Native, compared with counties with fewer Native Americans. My presentation today builds on Dr. Sunny's initial work. I am not a statistician, and statistical tests of significance were not performed. What I can show is that even simple descriptive analysis can be very effective in identifying disparities. So, where were those counties that were identified? This map shows the 61 counties with more Native peoples highlighted in orange. You can see concentrations of Native people in Alaska and American Indian people in Montana, Wyoming, North and South Dakota, Arizona, New Mexico, and in Oklahoma, as well as in a few counties in other states. In order to better understand differences between the two groups of counties, we looked at two other characteristics, rurality and the CDC's Social Vulnerability Index applied to COVID-19, called the CCVI. The CCVI uses ratings of social vulnerability to estimate risk for greater impact of COVID-19 disease due to geographic, social, and economic conditions in those locations. We learned that most of the counties we identified with higher populations who were American Indian, Alaska Native were rural and had higher social vulnerability. As in the maps, in the bar graphs and other graphs I will be sharing later in the presentation, I have indicated our counties of interest with orange and the other counties in blue. The bar graphs show the number of counties in each category, rural or urban, and with higher or lower social vulnerability. In the top graph, we see that there are more counties in the rural with higher vulnerability category. As a comparison, other counties across the country shown below are more evenly distributed across these categories. So how much does rurality affect COVID-19 outcomes? When we look at the actual impact of COVID-19 on all US counties, by rurality alone, we see that rural areas, which are shown here in green, experienced spikes of higher rates in May and July last year and in April of 2021. However, the total cumulative rates do not show a consistent pattern of differences between rural and urban counties. How much does the Social Vulnerability Index affect COVID-19 outcomes? For all counties by CCVI alone, we see that the more vulnerable counties shown in purple experienced earlier COVID-19 cases and higher rates in all three cumulative measures than the less vulnerable counties. This finding is consistent with the purpose of the CCVI and may be evidence that CCVI can be a good indicator for risk of disease in communities. So the counties we identified with 20% or more of the population who were American Indian, Alaska Native are fewer in number and only represent a small percentage of the total US population. So when we look only at case counts in the top line chart, they do not seem like a very significant group. However, we are talking about nearly 1.5 million people in these identified counties. When we look at the case rate per 100,000 people in the bottom chart, these counties were significantly impacted. We expect more variability for this smaller population, but notice also the markedly higher rates last summer, in January, and in April of this year for those counties of interest. The rate of cases is even rising in August, faster than in the general population. The total cumulative impact to date is significant, about 3.5 times higher. The same assumptions apply to death counts on the top and rates per 100,000 people by county, as shown here. Again, there is more variability and a pattern of higher death rates overall for the counties that we identified. In addition, the total cumulative impact is nearly 5 times higher. We see similar patterns in the case fatality rate for these counties. Case fatality was very high for everyone at the beginning of the pandemic before we learned what works best in treating this disease. Therefore, for this slide, I have excluded the first 3 months of 2020 in order to zoom in our view a bit so that we could better see what was happening in June of 2021. At that time, we saw a higher pattern for the counties of interest than in other counties, where other counties had a spike back in April. The total cumulative case fatality rate to date for our counties of interest is higher. The good news is our efforts with our partners, in combination with efforts of others, to raise awareness of the impact of the COVID pandemic on American Indian, Alaska Native communities seems to have had an effect. These counties we identified received vaccines earlier and have had a greater uptake to complete the full vaccination series. As of August 9th, the American Indian, Alaska Native counties of interest had fully vaccinated 44% of their adult populations. The Indian Health Service, tribal health partners, and others, particularly in the locations we identified, now have data to support seeking additional resources for their communities. I hope this presentation has given you food for thought as you consider why stratifying your data by race may have value. I have references available for the publicly available COVID-19 census and USDA data we use to characterize and group counties for this analysis. Please reach out to me if you would like more information. You can reach me at ttreasure@comagine.org. Thank you for joining us in exploring why you might use public data sources and potentially your own data to stratify health data by race. Even when the data you have is less than perfect, there are ways to use stratified data to impact health for your populations. Welcome, and thank you for joining us. Today, we are going to start with why. Why would you code, visualize?
Well, thank you, Traci. It's very interesting as Traci and I were chatting a little bit earlier this week over email, and I was just saying that I really appreciated your point about the clarity of results sometimes with just simple descriptive charts and without resort to fancy statistical techniques, because sometimes the data are just that clear. So from our audience, we have a question from Lorraine Brown. Do you know if boosters are going out to the tribal elders?
I don't know that. I'm now working on a different project, so there are still a lot of focus on these communities, and other partners are working with them. I just don't have up-to-date data myself.
Okay, thank you. Also in our conversation earlier this week, we had talked a little bit about data sources, and you had mentioned you had some thoughts about some data had become available since you'd performed your analysis, and wondered if you could share a bit about that.
Yeah, as we have seen across the country, the vaccination rates are still going up pretty quickly, and we're seeing higher rates than what I was able to show with the data I had available earlier in preparing this presentation. And more things will change in the future, and the important lesson that I have learned is just to try, be creative, find different ways to answer your questions. There's a lot of data available that we may underuse.
Great, thank you. Oh, actually, a great question from Imelda Flores. How did you choose the 20% threshold?
So my understanding is kind of by trial and error. Dr. Sunny went through what she could gather out of characteristics of the communities from the American Communities Survey that it can be used for demographics by county. And she used the publicly available COVID death and case data from USA Facts and just tried different proportions of Native American populations to see where there was the most difference. And that seemed to be a natural cut point to be able to see the difference between the two groups of counties.
Thanks. And Samuel Holman asks about if you checked for and observed any differences in patterns by native populations by state, if there was regional variation.
Right. I think that's a great idea. It was outside of the scope of what we did to pursue that further, but that's a great question. I would love to see further study into this data to answer questions like that.
Great. Okay, thank you. Those are the questions we have. Thank you, audience, for those questions. Those really good food for thought. Traci, do you have anything else that you wanted to be sure and share before we move on to our next presentation?
It's been interesting to explore this data, and I appreciate the opportunity to share it.
Thanks. Okay. Our next presenter is Alyssa Harris of Vizient. She's going to talk to us about the use of social determinant ICD coding in the COVID-19 pandemic. She collaborates with physicians and researchers on retrospective clinical research using administrative discharge claims from the Vizient clinical database. In this role, she serves as a subject matter expert on using the Vizient clinical database for study design and analysis. She has a bachelor's degree in science from the University of Notre Dame and a science business from the University of Notre Dame, and is a master of public health from the University of Michigan.
Vizient, and today I'm going to be talking about social determinants of health coding, ICD coding during the COVID-19 pandemic, and specifically that intersection of patients who have both of codes for social determinants of health and COVID. So who is Vizient? What is Vizient? We are a member-driven healthcare and performance improvement company, which essentially means that hospitals, hospital systems, and providers can come together to collaborate, to learn from each other, to transparently benchmark off of each other in order to drive healthcare forward in the country. And the tools, one of the tools that they use for that is the Vizient Clinical Database, which is a facility discharge claim database. Right now, as of now, we have over 800 hospitals that contribute to this, and that represents over 97% of US academic medical centers, over 8.5 million inpatient discharges per year, and over 130 million outpatient discharges, and that's across regions in the US, across payers. So it's very rich data that has a lag time of about 30 to 60 days from discharge. So it's also very fresh data. So today, specifically what I'm going to be focusing on is social determinants of health. And what those are where people live, where they work, where they play, where they worship. And all those things factor into their health, their quality of life, and their outcomes from that, and their risk factors for those outcomes. There are 5 main pillars, which are neighborhood, economic stability, education access and quality, social and community, and then healthcare access and quality. And all those come together to contribute to some very wide and known health disparities and inequities. And where COVID-19 comes into play is that there's been research that shows that pandemics disproportionately affect the poor and disadvantaged. So people who have poor social determinants of health will be disproportionately affected by COVID-19, and that's been shown as well. Homeless families specifically are at risk for infection due to their crowded living spaces, as well as their limited access to the screening for COVID and testing. Black and Hispanic populations also experience disproportionately higher rates of infection and mortality, but that's not because when they get infected, they are more likely to die. It's just, it's more a product of them being more likely to be infected due to differences in their healthcare access and their exposure risk. So what I wanted to do was to take some ICD-10 codes during the pandemic 2020 and a little bit into 2021 compared to 2019 to see if over time social determinants of health codes are being used more frequently because they have been shown to be underutilized in administrative claims data. And so I wanted to see if during the pandemic that improved. And then I wanted to focus specifically on the differences between patients that had that code versus patients that didn't have those codes. Again, so I used the Vizient clinical database to pull my data from, and then I focused on patients who had a Z code, Z55 through Z65 for social determinants of health, and those with a COVID-19 diagnosis of U07.1, which was effective as of April 2020. So over time for the uptake of these social determinants of health codes, you can see in the first part. So I started in January 19 pre-pandemic. So there's a slight increase over time. So these are patients out of all inpatients, the proportion that have any social determinants of health code attached to their encounter. So over time, you go from about, a little under 3% through the end of 2019, you're getting closer, a little over 3%. And then when the pandemic starts, you can see an increase in all patients having a social determinant of health code from about 3% to about 4%. Is that a product of patients who who do not have social determinants of health avoiding the hospital, and that just the proportion of people going have less education about avoiding the hospital? That might be at play. And non-COVID patients pretty similarly mirror the total population because they're a bigger proportion. But when you look at COVID patients, we discussed in the background how people with risk factors for social determinants of health actually were more likely to be exposed to COVID and be infected. But when we look at the overall proportion of patients with COVID that have a social determinant of health code attached to their encounter, it's actually lower than the overall cohort. And to me, that represents an opportunity within healthcare to attach these tags, even though they don't impact reimbursement at all, just for more being able to follow and track these patients. And then towards the end, which is June of 2021, you finally see an increase, more patients than the overall cohort with COVID being attributed to having a social determinant of health. So overall, the trend in 2020 into 2021 has increased, dipped down a little bit. So we're around 4% of all patients have a social determinant of health code, which again is low compared to what we would expect. So what are the top codes that we're seeing in these patients? So the top codes we're seeing are mainly ones related to the homelessness is the top one. So a little less than half on both non-COVID and COVID patients have homelessness as their top code. And then beyond that, it seems to be in that social context. So problems related to living alone, insufficient social insurance and welfare, disappearance and death of a family member, which is bereavement. And, it's not a far leap to think that someone who is in the hospital for COVID also lives with someone else who might have been infected with COVID as well and perhaps died. Social exclusion and rejection, and then other problems related to primary support. So a lot of these social context factors are coming into play here. So then looking at the difference between the patients based on whether or not they had COVID and a social determinant of health code attached to their encounter. So patients on average were about a decade older if they had COVID, which is not surprising based on what we know that COVID disproportionately or infects older people at higher rates and is more severe in elderly populations. So not surprising to see that overall COVID patients were, over a decade older. But the patients who had a social determinant of health code attached were slightly younger than those that did not have one. And going back to our top codes, homeless was a little less than half of the patients. And it's been shown that homeless patients are predominantly, they're more male and younger than the overall inpatient population. So looking at that might be explained by that. And then on the next slide, we'll see sex. The presence of having a COVID diagnosis, those patients are more male. And then similarly, patients who have a social determinant of health code are also more male. So between those patients that are in that negative top left and the patients that are in the plus bottom right, there's a little less than a 20% more males in that bottom right corner. And again, that might be because we saw such a strong presence in that homeless population. Looking at race, when you have patients who had a COVID diagnosis were more likely to be Black or other race compared to white. And then also with that social determinant of health code, they were more likely to be Black or other race compared to the white population and the negative top left corner. Looking at ethnicity, patients with a COVID diagnosis were a little less than twice as likely to be Hispanic, so 10% versus 18.9 in that top left corner. However, when you look at the presence of social determinant of health code, it doesn't look like that looks much different between those two. So those populations don't look much different. So you can see a 1% difference in the non-COVID side and a 2% difference in the COVID side. So those are more similar. That's not as impacted in the social determinant of health category. But as we saw in the background, we do know that Hispanic population are disproportionately impacted by some of the social determinants of health. So this might be one area that is really undercoded for social determinants of health. So looking at the outcomes, unsurprisingly, patients who had COVID had longer lengths of stay than overall inpatients. About 3.5 days more for the non-social determinant of health code, and then patients who had both COVID and a social determinant of health had over twice as long of a stay as patients who didn't have COVID or social determinant of health. So very significant increase in length of stay when you have a social determinant of health code added to your stay. When we look at ICU days, it's actually pretty similar though. So it doesn't seem like those social determinants of health are really impacting your ICU stay. And if anything, it's slightly less. And that might also be because when we go back to age, these patients are slightly younger.
Great. Well, thank you so much for that, Alyssa. The thing that really jumped out at me about the results that you shared were the prevalence of the homelessness code. Is like when the SDOH codes are used, almost half the time it was the homelessness code that was showing up. And I was just wondering if you had any thoughts to share about why that might be and what's going on there, and any more. I noticed you did mention some drill downs into that homelessness cohort but any other thoughts about outcomes and so on?
Sure. I think that one of the reasons it might be more present in the coding is that, first of all, it impacts your reimbursement because you need somewhere to send a bill. So that could be a main reason that it's making its way there. Also, it might be there because you need to connect patients to social resources. So if you have patients where you need to coordinate discharge or other factors, then having that code is probably more likely. And especially when it comes to something like COVID, where if they're coming from a shelter or an encampment and they have COVID, they're COVID positive. If you're discharging a COVID positive patient and they might be infectious, you might be more likely to hold on to them and keep them in the hospital rather than discharging them, so that you can prevent some further transmission. And then we saw that maybe played out in the longer length of stay in that population. I did do a drill down and I looked at the overall social determinants of health, all patients versus just the homeless patients. And a lot of it made sense. When I looked at just homeless patients, they were about 3/4 male versus if you grouped everybody together, it was 2/3 male, and then compared to the overall, which was closer to half. So they really drove up the male part of it. They were slightly more Black, about 4% more Black than the overall cohort. And then they also had slightly lower ICU stays. And that could, again, be tied to lower acuity, but longer lengths of stay because of the social need and not discharging because they have to connect and coordinate that.
Great, thanks. Question from some of our fellow presenters. While this is historical, has this data informed any interventions to connect patients with care and services to address the needs they are presenting with?
Yeah, so that's a very hospital by hospital basis. If you look at how the codes are utilized at specific hospitals, it's very clear that there are some hospitals that are much better at incorporating these Z codes, and that might be because they have some programs in place where they have initiatives to include these because they have resources that they derive from them. So it's really specific to the hospital and how they use these codes because they aren't necessarily tied to reimbursement. So including them is really a choice. So I think there are some that are better than others.
Okay, thanks. Okay. So that actually another question that I had was just really in interest of hearing a little bit more about the Vizient database. I know in your presentation you shared, I believe you said it was quite a number of academic medical centers and so on. And I was just wondering if there were any sort of high level sense of sort of like, for example, urbanity of the data, and so forth, any demographic overview that you might be able to share about that the data source.
Yeah, currently I believe there are 49 states represented within the database, over 800 hospitals. Historically, it started as an AMC centered database and their affiliates, but over time we've grown to community-based hospitals as well. So because of that history of the urban or the AMCs, it was historically more urban, but we're becoming more rural. I don't know the specific proportion, but it's becoming more representative of that rural area as well.
Oh, great, thank you. And great minds think alike. Dr. Sunny asked us what the geographic locations instead of the 49 states. And you mentioned AMC, I believe was an acronym. Could you?
Yeah, Academic Medical Centers.
Academic Medical Center, okay. All right, that makes a lot of sense, okay. And let's see, okay. So, I got a couple more questions from the audience, from Samuel Holman. We had a question that I had just seen here in the chat about whether all the data submitters are using the SDOH codes, and you had addressed that briefly a moment ago. And so are combinations of SDOH codes conditions common? Seems like that might exaggerate even more differences in outcomes from Samuel.
Yeah, that's a good question. And the answer to that is yes. Usually you see them, there were the 5 buckets of social determinants of health, and usually they seem to be clustered within the data. So if they're talking about education, and they're more likely to be coding those education, as well as, underemployment or food needs. So I've noticed that when I see them.
Thanks. And from Imelda Flores, do you care to speculate why the patients with coded SDOH are younger?
Well, I think that's a good question. I think overall patients are, especially when it comes to COVID, are older and more acute. Those with social determinants of health, I don't know. I really don't have any nothing comes to the top of mind, but I know in our particular cohort, it's driven by homelessness, and we know that cohort is younger.
Okay, thanks. All right. Well, again, thank you very much for your presentation, Alyssa. And with that, we'll move on to our third set of presenters. Heidi Chrisman and Bill Balderaz will be discussing their utilization of data visualization to promote health equity in distribution of the COVID-19 vaccine. Heidi Chrisman is the Chief Operations Officer of the Healthcare Collaborative Greater Columbus, a nonprofit organization dedicated to improving the quality, delivery, and value of healthcare and the overall health for all people in the Columbus region. And Bill focuses on helping organizations use data to power marketing and communications. Previous to founding Futurety, Bill was the founder and president of Web Marketing, which went from a one-man consultancy to one of the fastest growing interactive marketing agencies in the Midwest. And he's spoken at more than 150 conferences from New York to California about innovation. Heidi and Bill.
Good afternoon. I'd like to thank NATO for having us today. My name is Heidi Chrisman, and I am the Chief Operating Officer of the Healthcare Collaborative of Greater Columbus.
And I'm Bill Balderaz. I am the President and Founder of Futurety.
So today I'd like to introduce HCGC to you all. We have a mission of working with community providers and organizations to help provide people in the Columbus, Ohio area with the best healthcare experience possible, one that is high quality, well coordinated, affordable, and equitable. So in order to achieve our mission, we partner with many health and social service organizations. And in the case of this project that we're highlighting today, we've partnered with Partners in Health, which is a global health equity group, as well as Futurety, which is a data analytics firm here in Columbus, Ohio. As COVID-19 continued to spread in our community and beyond, HCGC, PIH, and Futurety joined forces to understand how data visualization can promote health equity in the distribution of the COVID-19 vaccine. We all unfortunately know now that the COVID-19 pandemic has been amplified in marginalized populations, including Black, Latinx, and Indigenous communities that have been disproportionately impacted as a result of the public health crisis of racism and inequity. To ensure that historically marginalized populations and communities have equitable access to the COVID-19 vaccine, we determined as a group that the following must be considered. The physical location of vaccine distribution must be in proximity to vulnerable communities. Transportation access, including the time and cost to travel to vaccine sites, must be considered. And the time and of week and day of the vaccines must be provided.
Thanks, Heidi. Now, to understand access issues for vulnerable populations, Futurety created a data visualization, essentially an online dashboard, and mapped vaccination locations, and then overlaid social determinants of health and public transportation data. Then we looked at vulnerable populations not as a single cohort, but as subpopulations who may face different barriers. Now, without this data, we may have ended up solving the wrong problem by focusing on an average population that didn't exist. There's a story data analysts love to tell that at one point the US Air Force was trying to design the perfect fighter jet seat. And they took the average of every pilot in the Air Force, their weight, their height, their proportions, and they designed a seat that didn't fit anybody because it was an average, and so the pilots got in and it didn't work out. We didn't want to make that same mistake here. So after mapping out the vaccine locations, the social determinants of health, and the public transit data, we then looked at how do we knock down barriers for very specific populations. Now, here's an example. Neighborhood A could have comparatively better access for Black populations than other neighborhoods, but have poorer access for new Americans. Neighborhood B could have better access for new Americans, but poorer access for people over the age of 65. Now, that would indicate to us that there are different solutions needed in each of these neighborhoods or tracts to solve those problems. Most of the data sources that we use to create these visualizations are publicly available. So the organizations at this conference today can use this, recreate the project, and drive action in their own communities to provide better healthcare access to disadvantaged populations. With this data, HCGC, Partners in Health, they'll work with existing retail pharmacies, local federally qualified healthcare centers, hospital systems, and community organizations here in Columbus to develop a plan to bring increased access to the COVID vaccine to our community.
Thanks, Bill. I'd like to also just outline the role that protected health data played in this project. So we had the opportunity to partner with an epidemiologist at the Ohio State University College of Public Health, who through the Ohio Department of Health had access to trusted health data such as COVID case rates and vaccine uptake rates. We as community-based organizations did not have access to that data, but we were able to provide him the community-based data that we had. He could combine that with that protected health data and make real-time recommendations to local health departments and local health systems on where to place mobile and pop-up vaccine clinics based on lack of access. So back to Bill's point, the work that we did was community-based, and you all can apply that in your own communities with the same sort of data. And we're already seeing at HCGC how we can apply this mapping project to other public health initiatives in our community as well. So now we look forward to sharing the interactive dashboard that maps vaccine access with you all. So now we'd like to just quickly show you how you can access this equitable vaccine mapping tool on the HCGC website. So if you navigate to hcgc.org and go up to pandemic response, you'll see a drop down that says equitable vaccine mapping. Click on that and it will take you to this page that will first provide a short YouTube video that Futurety created that will show you how to use the tool. So that 3-minute video will show you how to then scroll down and play around with the tool, think about how you can apply it in your community, and please reach out to us. Thank you so much for having us today. If you need to contact us, our information is on the screen. Thank you.
Thanks.
Okay, thank you, Heidi and Bill. This is really interesting stuff. I did have a chance to go out and use the interactive dashboard a little bit earlier this week, and it's really, really very cool. And I was wondering if you had any success stories you would like to share about cases where the dashboard was used to expand access.
Sure. Thanks for having us. So we had an instance, we're using it to place community health workers. So when you talk about using SDOH codes in hospitals, what I was sitting here really wanting to hear was that all of those folks were connected with a community health worker, and that community health worker addressed those needs. And so that's what we're doing at the Healthcare Collaborative of Greater Columbus, but also with this mapping tool. So we had a church reach out to us that said, you know, we have a lot of hesitancy here, but we also have people that we feed every week and they want to come back inside. They want to come to worship, but we can't get folks to get their vaccine. So we zeroed in on that census tract where that church is located. And we were able to say, okay, we've got community health workers that are a part of our Central Ohio Pathways Hub, which is a care coordination system that deploys community health workers. We also have a federally qualified health center right down the road. And we could visualize all of that through the mapping. And so with that, we were able to send a couple of community health workers to some of those community meals that church was holding. And then also, you know, share information, answer questions, sign people up if they wanted to be, and then also just direct them down the street to that FQHC that's offering vaccine. So really successful example there of how we were able to use it.
Right. Thank you. That's really great. Imelda Flores asks, can you tell us a bit more about how public transportation data were used? What format did it come in? And an excellent point that those data in particular sound hard to ingest, merge, and interpret.
Sure, I can speak to that a little bit. So again, we're based here in Columbus, Ohio. We do a lot of work with what's called the Smart Cities Initiative here. And so that it's also called the Columbus Operating System. So essentially, our region has made the decision to open up data related to CODA, which is our public bus line, the primary source of public transportation here. And there's also subsidies that exist for things like taxis, Uber, some of those other transportation as well. But essentially, you can go to the Smart Operating System in Columbus. You can download CSV files of this raw data that's publicly available and easily shared, and then pull that into like a Microsoft BI or Tableau platform, and then overlay it onto a census tract map.
So sort of creating sort of an index of how well served a particular area is.
Exactly. So you find, people talk about food islands a lot or childcare islands. There's also the transportation islands. So understanding this census tract is very underserved, overlaying that with social determinants of health in that same census tract, and then looking at vaccine availability within that census tract.
Another thing we looked at was distance. So how long it would take someone to drive from a certain census tract with a very high SVI to one of the mass vaccine locations. And in some cases, the other social determinants involved in someone's life, like having multiple jobs, having children with no childcare, all these things that are encompassed by SDOH, really were impacted by the fact that there's no way they're going to be able to find the time to drive for 2 doses to another place, find parking, all of these complex issues. And that's what really informed using that trusted health information to send vaccine to people where they are, meet people where they are, so that it's easier for them to access the vaccine.
Right. Thank you. And let's see, I think that's everything we've gotten from the audience so far. Norm, would now be a good time to put us all in. There we go. Yeah. Okay. Thanks. One thing that struck me is that we had two analyses here, Traci's and Heidi and Bill's, that used social vulnerability indices. It sounds like, and Traci, you were using a COVID specific one, I believe. And I was just wondering if there was, Heidi and Bill, if there was more, if that was the same one you were using, or if not, which one you were, if you could share a little bit more about that.
Yeah, so we use Social Vulnerability Index. We are familiar with the CCVI, and through Partners in Health, the Healthcare Collaborative of Greater Columbus is one of their sites here in the United States that they funded to do some technical assistance. And so we've done a lot of learning with other groups. And I know that their group in Chicago used CCVI to do some vaccine outreach and mobile unit placement. So we just, with the way our data kind of layered, it just made sense for us to use the SVI and then let our public health partners at Ohio State University really dig in and use that, the vaccine uptake and the case rates. It just made more sense for us for this specific project.
Interesting. Great. Cool. Let's see, we see if we have more questions from our audience. Any comments from any of the presenters for the other presenters while we're?
Sure. For Bill and Heidi, how, I don't know if I missed this, how frequently are you refreshing this data, or is it stagnant and just kind of like a snapshot and then the coordination comes down the line, or is it updated?
So we're kind of in that space right now of reevaluating. A big part of the tool early on was using our local health department's equity dosing forms. So you were able to click into that form and request that the county health department come out and do a mobile unit for a specific community. And they don't offer that anymore. There's not the need for that. So we are, Alyssa, really reevaluating what data we're going to include. We're taking out all the back sites because they're not there anymore, right? The game has changed. So we're looking at how we can still deploy community health workers and apply it to other things like chronic disease, flu shots, when we get to a space where 5 to 12-year-olds are able to be vaccinated, using it for those purposes. So we're really excited because we'll be able to continue to apply it, just in different ways.
I guess as a follow-up, you kind of are alluding to this. Have you thought of any further uses for chronic diseases of interest that you might want to use this model on in the future?
Yeah, we had a really interesting discovery. We were talking about diabetes patients in our care coordination model that we do. And so we looked at all of our diabetes patients, or clients, we're not providers, so we call them clients. And we realized through the mapping tool that all of them resided in 3 zip codes. And looking at those zip codes, 2 were very high SVI. 1 was a very gentrified area right next to an area of high SVI that probably previously was very high SVI. So we're able to take that and again, do exactly what we did with the church that reached out and say, where is there a provider? Where are community health workers? And deploy them to those places specifically to do more canvassing and to try and get to the bottom of, what's going on, making sure that folks in that area have access to healthy foods and care to manage their diabetes.
Yeah, that's really neat.
Cool. Thank you. A question from Sani Ibrahimi, sorry. I'm wondering, how would the vulnerability index map to Z codes to see how they align at the population level?
I love that idea. I think I'm going to do that as a homework assignment.
I mean, the great thing about the map in general and the work all the presenters are doing is once the plumbing is built, the data that comes in can be changed, can be modified. It's built with the flexibility, so we can talk about infant mortality, we can talk about diabetes, we can talk about hunger, we can talk about malnutrition. So we can have all those discussions with the data coming in now that the tool and the intelligence is there. Certainly can apply to these other data sets.
Yeah, we have a primary care system here in Central Ohio that we were able to. They're thinking about, because of COVID, moving into less suburban areas and more urban, vulnerable areas, and we were able to walk through that process with the mapping to say, you've got this high SVI here, you have a high incidence of chronic disease or infant mortality, and they were able to use some of that to make decisions on where they want to place new clinics. So again, just more applications.
Great. Well, one thing I was also really interested in with Bill, you had mentioned in your presentation about tailoring solutions, for different different neighborhoods, different situations, and I was wondering if you had any examples of that or things that you had noticed in putting the dashboard together about how you might be seeing high levels of vulnerability, but distinct characteristics that might require a different solution.
Sure. And how you touch on a lot of these. So if you see a population, for example, with census data, we can identify young families. So in that case, childcare may be a solution to getting those adults into a vaccine site. You may see another area with very low vaccine uptake, but identify these aren't young families. And so offering childcare in that neighborhood isn't going to have an impact at all. So thinking more about looking at a population that's largely hourly employees that can't take time off, that might be messaging to employers, working with groups, influencers or government agencies here around, let's message to employers the advantage of giving time off, whereas you look to a segment where there's a high rate of unemployment, that messaging isn't going to matter. So let's not worry about that messaging there. So those are all based on real examples of things that we found and actions that can be taken.
Great. Well, thanks for that. These have all been very interesting. As we get toward the end of our time, I'd like to give each each panelist, each presenter, a minute to just sort of share their most important advice as other researchers might consider using some of these public data resources to look at social determinants and inequities and so forth in our healthcare system. And I'll start with Traci. Go back in the order that we went for the presentations.
Sure. As Sunny has pointed out, there are so many opportunities for more research to be done, and we don't have to wait for perfect data. There's plenty of public data out there available that could be used in creative ways, like the way she did for this analysis. There's a lot more questions to ask, and a lot of different ways that it could be used. So I just want to encourage people to try that, to try this type of simplified methodology to categorize zip codes, categorize census tracts. There's a lot of data available that can be used just geographically without having all of the data we wish that we had.
Great, thank you. Okay, Alyssa?
I showed how undercoded it seems like these Z codes are, but I think we're seeing still increasing use of them. And I think the more people use them and start to publish findings on them, the more visibility they'll get and maybe the more use they'll get at the hospital level. And from there, you might have the opportunity, as Heidi kind of alluded to use that data to connect patients with actual resources. So we have some data and it's very rich what we do have. So being able to get insights from that small, 4% of inpatient discharges, if you can imagine how much more powerful it would be if it was actually capturing everything, I think that would be really, really great for research and for connecting people to the resources that they need.
Thank you so much, Alyssa. And then finally, Heidi and Bill, we'll come back around to you.
Sure. I just would want to close my remarks by saying that at HCGC, we believe that health is a human right, and data can be used to inspire action to address racism as a public health crisis and the inequities that are a result of that, and that it should really be used to meet people where they are and address those needs.
Great. Yeah, it's hard to follow that, but I would the kind of the general theme here. It's actionable. We don't want interesting data. We want actionable data, and it shouldn't stop with a spreadsheet or a map. That should be the beginning. That should then be the first domino that inspires us all to take action.
Okay, well, thank you all very much. This has been a blast. I really appreciate your work and your insights, and I'll turn it back over to Norm Thurston, NADO's Executive Director.
Thank you, Andrea, and thank you all to all of our panelists and to our audience for making us such a great session. We invite you to join us at 4:30 p.m. Eastern Time for our closing plenary. Well, I'm sure the highlight will be the content and the presentation, but we will also be announcing the winner of the grand prize drawing. So if you haven't put in your codes yet, go ahead and get that done now so you can be in that grand prize drawing. We'll be doing that, drawing it around halfway through that session. So thank you, everyone, and we'll see you in just a few minutes. Bye-bye.
Thanks, everyone.
Thanks.